Hi, this is Anthony Effinger. I'm here at the Think Neuro podcast at the Pacific Neuroscience Institute. I'm talking today with Dr. Melita Petrossian, who's the director of the Pacific Movement Disorders Center here. Thanks for joining us.
Thank you for having me.
So tell me how you got into this neuroscience business. When did you know you were going to be a neuroscientist?
So I always knew I wanted to be a doctor from third grade. First time I learned about the human body, I thought it was fascinating. I was like, I want to do that. But by the time I got to med school, I was already really fascinated by the brain. I had studied psychobiology in college, and I was trying to decide between internal medicine.
Psychobiology?
Psychobiology. It's sort of an offshoot of neuroscience. It was
Okay.
basically kind of the psychology department's version of looking at the neuroscience of psychological things like learning and behavior. So it was a little bit of a mix of psychology and neuroscience.
And this is college.
This is, as an undergrad.
Where?
Yeah, UCLA.
Okay.
Yeah. And then I went to UCSF for medical school, and I was leaning towards neurology, but in my third year, I did internal medicine and I loved it. So I was kind of trying to decide between the two, and I gave myself till the very beginning of my fourth year to make a decision. And I just really found that the brain is just the final frontier of everything that's so interesting of, what we're learning about it, and, so much more that we need to do and learn about. And so when I made my decision and started my first 3 days of neurology residency, I was like, oh, this was the right decision. This was amazing. I'll never look back. And then once I was a neurology resident, I had to decide what I would want to subspecialize in. And I got interested in movement disorders because it's a very clinical field. It focuses a lot more on what does the exam look like compared to, what does the scan look like, or what does the blood level look like. And I really love that I can see young people and old people, people who have something really minor that's easy to treat, something that's very complicated and challenging, men and women. So it's been a really, really great fit for my personality of really liking to sit down and talk to people about what's going on and how they can be benefited by treatment.
And you chose to practice here in your hometown.
Yeah, so my husband and I are both from Los Angeles. So after I finished my fellowship, we both came back out to LA.
And the fellowship was where?
At Harvard University, Brigham and Women's Hospital,
Yeah.
and Mass General Hospital.
Got it. I've heard of that.
Yeah, most people have.
Yeah. Okay, so you came back from the East Coast.
I was at UCLA for a short time, and then I got recruited to develop the Movement Disorders Center here at Pacific Neuroscience Institute, and that was in 2016.
And did you know Dr. Kelly and his colleagues from other?
So actually, I don't know if this goes in the podcast, but my brother is Dr. Garni Barkadarian.
Oh.
And so he'd been working with Dr. Kelly since he finished his fellowship, which we were actually both at the same hospital, Brigham and Women's, for fellowship. So we overlapped for a year. So he had been working with Dr. Kelly since 2012. And then he let me know, hey, they're looking for a movement disorder specialist. And so it wasn't nepotistic, I promise. No, we I met with Dr. Kelly, and it was a good fit.
Sure.
Yeah.
So wait, you have you have a neurologist and a neurosurgeon in your family?
The family, yeah. Mm-hmm.
Okay.
And then my sister-in-law is a pediatrician.
Okay, so it's a small world, and that's fantastic. Mm-hmm. So you kind of practice with your brother.
Yeah, so we share only a small percentage of our patients, but for example, within movement disorders, I see people who have hemifacial spasm, and he might operate on some of them. So I send him patients to operate on, and that's sort of the overlap mostly.
When I think of movement disorders, I think immediately of Parkinson's. Just, I have a friend who has Parkinson's, and that's what I think of. But tell me what else is in that.
So the vast majority of what I do is Parkinson's.
Okay.
But the other things that are considered movement disorders are tremor, like essential tremor, other Parkinson's related conditions like dementia with Lewy bodies or progressive supranuclear palsy. And then
what's essential?
Oh, right. So essential tremor is actually the most common movement disorder.
And why is it called essential?
Oh, that's a great question. So I don't like this terminology.
Okay.
This is a medical terminology where the concept is the essence of the condition is tremor. So it means that it is what it is. So essential tremor means tremor not caused by something else.
Not a symptom of some other...
Not a symptom of
Okay.
Parkinson's
Okay.
disease, for example. Not caused by a stroke.
Okay.
It's just what it is tremor. So essential tremor. It's the same thing as calling somebody who has regular old high blood pressure, calling it essential hypertension.
Okay.
Yeah, I don't like the term.
Okay, so what causes essential tremor?
So essential tremor is a brain condition. So in that sense, there's a similarity to Parkinson's, that it is a brain condition and it is a neurodegenerative condition, meaning it does get worse over the years, but it takes many decades for it to progress compared to Parkinson's disease. It is caused by, as best as we know, problems in the back part of the brain called the cerebellum.
Mm-hmm.
And there's a balance of signals in the brain. So there's actually two deep parts of the brain called the VIM of the thalamus, where the tremor is actually generated. It creates our natural rhythm of our brain. And naturally, the back part of the brain, the cerebellum, should silence the tremor generating signals from the thalami. But in the case of essential tremor, it does not. So that's how the tremor comes out.
Okay. So you see cases of that.
I see that. I see dystonia. I see...
What's dystonia?
Dystonia is abnormal positioning or posturing of a body part or the whole body.
Interesting. Really?
Mm-hmm.
So you're in a state of abnormal
posture. So if you ever see somebody who's got a neck kind of twisted or turned to one side, that's cervical, meaning neck-related dystonia. Or if you've ever had a rider's cramp or a foot cramping in, that's a very, very brief moment of dystonia.
So it sounds like you're treating something that's a persistent dystonia. And is that again caused by
the brain?
Okay.
That's some of it is genetic, and some of it, when it's focal, like the rider's cramp, is thought to be what's called maladaptive neuroplasticity, meaning that neuroplasticity is a concept that the brain can change physically and chemically and circuitry wise with behavior or with input over the years. And maladaptive means it's not a good thing.
Certainly. Right. Okay. But the vast majority of your cases are Parkinson's.
Absolutely. Yeah. Okay. It's a huge part of what I do. And part of the reason for that, despite the fact that essential tremor is way more common than Parkinson's,
it is
8 million versus 1 million.
Interesting.
Americans anyway. The Parkinson's really affects people in so many more ways other than just the movements and just the tremor, certainly, as well as the fact that it progresses more rapidly. And there's a lot, actually, frankly, there's a lot more conversations and discussions about the types of treatments that are available. So there's a lot more research happening on Parkinson's disease. So it tends to be a much larger part of a movement disorders practice.
Could you live for a long time with essential tremor where you can't probably live a long time?
Yeah. So essential tremor causes tremor and then some gait imbalance.
Okay.
So walking and balance issues. But other than that, nothing else.
So Parkinson's, though,
has a lot more.
You've got So I have a friend, an old friend of mine who has Parkinson's, and he's got Parkinson's related dementia now.
Yeah.
And he doesn't recognize anybody. And I've watched it happen over the years, and it was devastating.
Yeah, it's really tough.
It was really tough. And he's, God love him. So I know a little. I know very little. I've had some exposure to it, and it's terrible. So tell me how, when people come to you, what symptoms are they having? Where are they at when they start to notice Parkinson's?
That's a really great question. What's so fascinating is that it can really vary. The first symptom of Parkinson's that a person might experience might be a tiny little twitch in their pinky finger.
Oh my!
And I'm not trying to alarm you about any of the random twitches.
Right, I know. I'm going to start developing them all now.
Yeah, exactly. As we sit here, you're going to gradually
I'm going to get them all.
Symptoms.
Go ahead.
So literally, for example, if you read Michael J. Fox's book, that's what his initial symptom was. It was just a very small little tremor in a finger that was intermittent initially. And I'm not going to speak specifically to Michael J. Fox, of course, but just in general, these things can be very intermittent, very minor, almost unnoticeable. Sometimes people may have a what's called an internal tremor where they feel like they're shaking, but nobody can really see it. And then because the classic tremor of Parkinson's disease is what we call a rest tremor, that means that it happens when the limb is fully at rest, they can easily make it go away by picking up their hand or limb or holding something or using the limb to do an action, because the initial tremor may not have much of a what we call postural, meaning holding,
Okay.
or action, meaning with movement or use of the hand component to it. So it can be really minor and people can notice it but not think much of it, or notice it, ask their physician about it, and be told that it's nothing. And, a year, 2 years, et cetera, can go by. The other
with this sort of recurring, with this
yeah,
tremor
with it
at
developing,
rest,
coming
you
on a
feel
little bit
it,
more
you're like, "Ah, that's that."
frequently
Okay.
or more noticeably
Okay.
as the years are going on. Conversely, some people may develop a lot of the Parkinson's symptoms, such as stiffness, slowness, their posture may get stooped, their facial expression may become masked, their voice may become soft and hoarse, they may shuffle, they may have trouble moving one arm, like reduced arm swing on one side, they may drag one foot, they may even have falls. And they may not really think much of it. I see a lot of people where they're having actually a lot of symptoms, but not really recognizing them as anything problematic. And there might have been 1 year, 2 years, or even longer time that's gone by in retrospect when you ask them about it, where they really were chalking things up to, oh, I'm just getting older. This is my old shoulder injury. My back is acting up. And I've seen a lot of people really very remarkably kind of justify what's going on or write it off as something else and not recognize that actually it's Parkinson's the whole time.
What is happening in their brains in those early stages? Can you describe it to a lay person?
Absolutely. So Parkinson's disease is a brain condition, and it affects the part of the brain that I like to call the autopilot.
Okay.
So all of our movements are mediated by subconscious control. So when you decide to get up, walk across the room, grab a glass of water, come back and sit down, you are not thinking consciously about hip flexion and knee flexion and extension and arm swing and flexing your finger around the glass and lifting and pouring, etc. You are not thinking consciously about any of that. You're thinking about more important things. And all of the control and smoothness and speed and stop and go of your movements are being mediated by, as scientists, we call it the basal ganglia, but I like to call it the autopilot.
Where are we talking in here?
So deep in the brain. Yeah. So it's above the brainstem, right in the middle. One on each side. Are we in
reptile brain here? Or
yeah.
Okay. Yeah, like the older structures. Okay.
Yeah, well below the cortex. Right. Adjacent to the thalamus. So the thalami, there's one on each side. So the thalami are the relay stations, and then adjacent to that are the basal ganglia, which involve like getting you to move when you want to move, making you not move when you don't want to move, making the movement smooth, and also kind of targeting appropriately. That deep part of the brain is different from the back part of the brain, the cerebellum, which is Greek or Latin? Latin for little brain. And that is more for targeting and coordination, like finger to nose and those kinds of things. So people with Parkinson's may actually be able to target correctly, accurately, but just may be really slow on one side. And it's very typical for Parkinson's to begin on one side of the brain, gradually to spread to the other side, but for the difference to always remain, where one side is always worse than the other. But let's take a step back from there and say, well, why is this happening? Why is there dysfunction? Well, it's because of a loss of dopamine. So dopamine is a neurotransmitter, meaning it's a brain chemical that is involved in the signaling of the basal ganglia or the autopilot pathway. So the information going down the nerves and between the nerves and going back and forth is mediated by dopamine. So when you have too low dopamine, then it's almost like things kind of grinding to a halt. Things are slower, stiffer, smaller. But also there can be tremor, which is related to how the circuitry is not just about initiating movement and continuing movement, but also about stopping movement that we don't want, namely tremor. Why do we have low dopamine in people with Parkinson's? Because there is a protein called alpha-synuclein, which can form abnormal forms, and those abnormal forms can clump together.
Abnormal forms of
alpha-synuclein.
Okay. So, okay. Okay.
So we might call them toxic forms of alpha-synuclein. Okay. They clump together, and when they clump together, they gum up the works of specific brain cells, and then those brain cells die off.
Are these the brain cells that produce dopamine?
Correct, absolutely.
And the brain cells that produce dopamine are fairly rare in the brain, aren't they?
Well, there's two deep parts of the brain called the substantia nigra, or black substance, that is where most of the dopamine creating cells are, but then they project to the rest of the circuitry. So there's a lot of neurons that utilize the dopamine, but the ones that create them are deeper in the substantia nigra.
Okay. So what causes this clumping?
That's a really good question. So there's a lot of research happening on that. So to speak a little bit generally, we like to sort of differentiate between genetic and environmental. So the classic nature and nurture. So they do combine together. So the vast majority of people who have Parkinson's disease do not have a family history. About 85% of people with Parkinson's have no family history of Parkinson's. But it does appear that there's some kind of genetic risk factor for it that then combines with something environmental.
That maybe makes the gene express?
Exactly.
Okay.
So for example, if you have identical twins, there's not both of them would go on to develop Parkinson's disease based on what their environmental impact was. Some of the things that we are clear about environmentally are pesticide exposure, manganese like welding, those types of occupations.
Seriously.
And when we say pesticide exposure, we don't mean like, oh, I had an apple and I didn't wash it. We mean like you were as a child in the fields playing with people spraying around you, or you were a worker.
I mean, there's plenty of bad pesticides. We all know that. Okay.
Yeah. So but then of course the vast majority of people with Parkinson's, at least in our community, they haven't had those kinds of exposures. So there's a lot more that we're still trying to understand as far as the epidemiology of the development of Parkinson's. There's some theories about hormonal involvement, as well as, for example, caffeine intake, smoking, etc., and how they play a role. So it's a really interesting area.
Inflammation seems like it's a culprit for a lot of things these days. Is Parkinson's a disease of inflammation?
Yes and no. So it's not as clearly related to autoimmune inflammation, the way multiple sclerosis is, for example. It's not treated with steroids or immune modulating treatments. But it does seem like a lot of these neurodegenerative diseases like Alzheimer's and Parkinson's are influenced by years, or if not decades, of chronic low levels of systemic inflammation. And there's a theory, as far as the gut-brain connection goes, that inflammation in the gut can contribute to the conversion of alpha-synuclein into those toxic forms we were talking about earlier. And then the toxic forms of alpha-synuclein can travel up the nerve, which is called the vagus nerve,
Vagus nerve from
the gut to the brainstem. And then from there, travel into the deep part of the brain, the substantia nigra we were talking about earlier, to cause those brain cells to die.
And this starts in the gut.
There's some reason to believe that for some people with Parkinson's, it might start in the gut. For other people with Parkinson's, it might start in the olfactory bulb, which is the sort of the back end of the nerve that controls smelling in the nose.
What would happen? What happens there?
It's unclear, but again, that's the theory about exposure to environmental toxins
pathway?
That when you inhale them, that they would then kind of latch on from there, and then pathway into.
Okay, so that's another pathway. So talk with the gut. Is there a connection to constipation?
Yes. So very commonly, probably about 70 to 80% of people who have Parkinson's also have constipation.
Like chronic
constipation.
Caused by any number of things.
Caused by the gut slowing down.
Yeah.
So when you ask about, how do people know, what are the symptoms that they come to us with, when you think back to, or you ask them about what are your symptoms other than just movement or tremor, the vast majority of them have some or another of what we call non-motor symptoms of Parkinson's, and constipation is just one of them.
Interesting.
So constipation can happen because the gut has slowed down, and that is because the neurological control of the gut is also mediated by the same dopamine kind of pathways.
Okay, so it's not so much a cause.
That's a little bit of chicken and the egg. One of the theories behind the gut-brain connection, or the gut microbiome theory of how Parkinson's can begin, is if you've got chronic constipation and that results in an abnormal bacterial profile because things aren't getting flushed out properly, for example, those abnormal bacterial profiles could contribute to how the food in your gut is metabolized, contributing to alpha-synuclein abnormal formation of those clumpy kind of forms of alpha-synuclein, which then goes up to the brain.
So tell me about the other non-motor symptoms that people might see
or
feel before.
So the main ones I ask about are dizziness upon standing, which can be caused by what's called orthostatic hypotension, where the blood pressure drops when a person stands up. I ask about constipation. I ask about their sense of smell and taste. Because like we were talking about earlier, where if the alpha-synuclein goes through the nose instead of through the gut, or both, the olfactory bulb can be affected, and people can lose their sense of smell or taste for years before the development of the movement symptoms. And then I also ask about a specific dream-related behavior called REM sleep behavior disorder. So REM sleep is when we dream.
Mm-hmm.
And what is supposed to happen during REM sleep is that only our eyes are moving. That's why it's called rapid eye movement sleep. Our bodies are limp and paralyzed during REM sleep. In people who have REM sleep behavior disorder, their bodies are not limp. They're not paralyzed. So they can kick and punch and act out dreams. Very classically, the dreams are violent dreams, but the dreamer is not the primary aggressor. So they're either being attacked or they're being chased by something or someone, or they need to defend themselves or their loved ones against something or someone. And so they're kicking and punching and fighting off and yelling and screaming and that kind of thing. And that can precede the development of Parkinson's or Parkinson's related conditions by 8 to 10 years, sometimes even longer.
That's fascinating. Is this, again, a product of, this is all related to this dopamine deficiency?
Yes, I think that's fair to say it that way.
And
dopamine's not the only thing that gets involved with Parkinson's, but I think it's fair to say that.
Well, dopamine's the flavor of the month right now. Everybody's talking about it.
Mm-hmm.
So again, this is movement in your dream. This is movement while you're sleeping.
While you're dreaming. It's normal to move when you sleep.
But in REM.
But REM sleep periods there's usually 2 to 4 REM periods that last about half an hour each during your 6 or 7 or 8 hours of sleep. And it's those periods where you're supposed to be paralyzed.
Okay. So tell me what, I guess it's a hard question, but on average, when people come to you here, mm-hmm. where are they in this spectrum of symptoms?
A lot of times, if it's the first time that they're being diagnosed, they might be fairly early into the Parkinson's. So they might be functioning relatively well. They might still be working. They might feel like they're slowing down a little bit and not sure why. They might have a little bit of a tremor that they want to get evaluated, but the tremor isn't necessarily causing them a lot of problems. Or like I said, some subset of them may already be not doing well by the time they come see me.
And are they coming to you on their own, or are they referred?
Both.
Both.
So we get people who get referred by their primary care doctors, by their general neurologists. We get people who've read about it and looked online and came to us. Oftentimes, I think the ones that are self-referred are often people who already have been diagnosed with Parkinson's and they're seeking a second opinion.
And they notified you guys from...
Well, so we have a lot of community events. We have our website. We have our blog. We have a support group.
You have a reputation.
Yeah.
Yeah. Mm-hmm. Okay, so when they come into the program, what happens?
So I do a consultation. Okay. So I ask them all of the questions about what their movement symptoms, non-motor symptoms are. I ask them about family history. I ask them if they're taking any medications, either if they've tried it in the past or that kind of thing. And then they
medications for Parkinson's, like levodopa.
Yeah, like levodopa or rasagiline.
I don't know that one.
Yeah. So
good.
So during the examination, I look at all of these movement symptoms, or what we call motor symptoms of Parkinson's: tremor, slowness, stiffness, facial expression, speech, walking, balance, arm swing, etc. And then for each of those objective findings, I will give a number to it from 0 to 4, where 0 is normal and 4 is severe. And so it's a way to kind of quantify where they're at that day on their movement exam. And that's something that was developed by the Movement Disorder Society. It's the Unified Parkinson's Disease Rating Scale. So I calculate that. We typically will do a cognitive assessment at some point, either that day or another day. I don't typically obtain imaging unless there's something that is concerning for maybe this isn't Parkinson's and it's atypical Parkinsonism, such as they had a really sudden onset, so I might worry, was this a stroke? Or they might have a lot of gait in the absence of a Parkinson's type symptom, and I might worry about hydrocephalus, which is a different brain condition. Or if they're having a lot of dementia right at the beginning, cognitive issues at the beginning, would be a concerning feature for being atypical Parkinsonism or something else entirely. And so an MRI can be useful in those settings to look for other things that can cause similar symptoms and signs. But an MRI does not diagnose the Parkinson's disease.
Okay.
It doesn't rule it in or rule it out.
Okay.
I'll sometimes obtain laboratory evaluation if there's something else going on that's concerning for something moving too rapidly or something else that could be explaining it. Or neuropathy, for example, might want to do a neuropathy evaluation. And then if the diagnosis isn't clear based off of the examination, say, for example, they've got a tremor that's at rest, but they also have an action tremor. And it's a little bit of a mixed kind of appearance of the tremor, sort of in between essential tremor versus Parkinson's related tremor. We do have a test available here at St. John's called the DAT scan, D-A-T scan. And the DAT stands for dopamine transporter.
Okay.
So this is not an MRI or a CAT scan. It's a SPECT scan, S-P-E-C-T. And it's more like a PET scan, if you've heard of a PET scan.
Yeah, with it measures where you can visualize brain activity.
Yeah, so this will actually measure dopamine transporter levels.
Dopamine transporter levels.
Yeah, so it's the closest thing we can get to actually measuring dopamine in the brain, because you can't do a blood test. You can't do a blood test, no. And so the dopamine transporter, if it's reduced, then that's
dopamine transporter is a separate molecule.
Yeah.
Okay.
It's a
does exactly what it says.
Exactly.
Okay.
Transports.
So you're looking for the dopamine trucks.
Yeah.
Okay.
Exactly.
And by counting those, you can tell.
Yeah.
Sort of the level of dopamine.
Exactly.
Okay.
You can get a visual appearance of completely normal, or it's reduced on one side.
On one side.
Yeah.
Because you talk. Okay.
Mm-hmm.
All right. And then once you determine that somebody's got Parkinson's, this is a disease you can do something about, right?
Absolutely.
You can do things.
Yes.
So what do you get them doing?
So this is where I think it's really inspiring and really, I think, motivating to do this work, because even, let's say, 10 years ago, I think people weren't as aware of all of the power that they themselves have, of what they can do to really try as best they can to prevent the progression of Parkinson's disease.
Prevent the progression.
Yeah. Slow it down.
Yeah.
I'm not trying to oversell. I'm not trying to say we're putting complete brakes on it, but definitely make a difference in their outcome.
Okay. So
So, and when I say people didn't know, I don't just mean the patients. I mean, physicians may not have been aware of, how to advise people. So I always caution people when they think about, oh no, my friend had it, or my mother-in-law, or something like that. When you look at somebody else who's had Parkinson's for a while, you don't know what they've been through. You don't know what subtype of Parkinson's they have. You don't know what they've tried or what they didn't know to try. So I always try to caution people about, not thinking about their other people that they know when they think about what their journey is going to be like.
Because it's likely to be different.
It's likely to be different, not to mention we actually have much better treatment
we know,
than
right.
we did. I mean, there's already changes in what's been FDA approved for Parkinson's disease, even in the last 5 years. So if somebody comes to me with a new diagnosis of Parkinson's, there's several things I emphasize, but I like to break it down into lifestyle and medication. So unfortunately, neither of them are enough on their own. There's no magic pill that you take it just once and then you're cured. And even the medications that we do have, even though they can help quite a bit, they're really not enough on their own. Likewise, when you talk about lifestyle modifications, they're not enough on their own. But you put the two of them together and you can get as close to functioning well as possible for a lot of people. The tricky thing about Parkinson's is that everybody's a little bit different with what they're experiencing, but also everybody's a little bit different with how they respond to medication and treatment. But by and large, there's more that we can do than I think some people realize. And a lot of that is lifestyle. So what I mean by lifestyle is exercise, diet, sleep, social engagement, management of constipation, and advocacy and sort of learning about the condition itself. So the thing that most people really feel the most connected to is exercise.
Yeah, I was going to say that's
because a lot of people will go out and follow my advice, believe it or not, and then come back and I really feel great when I'm exercising.
Yeah.
I'm like, good. So it's working,
What sort of exercise?
So I go through, we have a P&I minute on this actually, but I go through the 5 aspects of exercise that are helpful. Cardiovascular, strength-based, so resistance training, stretching, balance training, and then what we call skill-based, meaning doing something that requires conscious awareness of what the body's doing. So for example, boxing is very promising and very popular now for Parkinson's disease. Yeah. Not that they're doing any brain or head contact, but you're using gloves and punching bags and mitts. So you're otherwise doing everything.
Now, why is that good? Because
So boxing programs that are designed for Parkinson's involve the cardio, like they do some, cardio there. There's also some balance training in most of the classes. But when they're actually got their mitts on, they're actually doing the boxing. You're learning something new. You're doing something different with left versus right. You're doing something different with upper body versus lower body. Plus, it's fun. You get to get aggressions out, that kind of thing. Yeah. So they really get into it. They really enjoy it. There's a great dance program called Dancing Through Parkinson's that a lot of people really enjoy. Again, you're doing something new and different with your body. You're learning a new choreography. And what's happening in the brain when you're doing that is that you're literally making new synapses in the brain. We have this, of course, from mouse models, rat models, but there's evidence that you can literally change your brain for the better by exercising. You can also make your brain utilize dopamine more efficiently when you're doing exercise, especially skill-based exercise.
You can make it utilize dopamine more efficiently.
So the amount of dopamine you have, you can use it better.
So is this the brain trying to adapt to this new skill?
Adapt, learn, challenge itself.
It sort of efficiently. That's fascinating.
Yeah. The other thing that happens is there's a protein called BDNF, the brain-derived neural factor, and it protects brain cells. It's involved in the neuroprotection pathways of the brain, and that gets released when you do cardiovascular exercise.
Fantastic. Yeah. Well,
but it has to be high intensity.
I've heard.
Now, I always tell patients they need to talk to their doctors, their cardiologists, because some patients who have Parkinson's also have cardiac issues. So I don't recommend anything without having them discuss it with their doctors. But if they can handle high intensity, it's better for them than a low intensity. They can get more out of it.
They get more of this.
Yeah. And the high intensity interval training is really cool because you can push yourself for, say, 2 minutes and then take a lower intensity and then push yourself for a minute and a half.
And you get the benefit.
And you get the benefit. Yeah. And you actually get much more out of that, even if it's a shorter period of time, like say 15 minutes total, rather than going for a walk for 2 hours compared to a walk for an hour or something like that. There's a lot of my patients, not walking is bad. So if you're not doing anything, going for a walk is great. But they will find, they'll tell me, I am walking, and they're not feeling that it's really helping them enough. They're just getting fatigued from it. And so that's the difference is, a lot of people, it's not just about telling somebody to exercise, it's about understanding what type of exercise is going to be helpful. So a lot of people have come to me and saying, oh, well, my doctor told me I need to exercise more. So I went from 1 mile to 2 miles, and all I'm getting is just more fatigued and, more back pain and that kind of thing. And so it's not about the duration, it's about the intensity. And then I always bear in mind, we want to make it as low impact as possible. So for a lot of people, having back or hip or knee issues, they're not going to do well jogging on the pavement. They want
what are the alternatives for them?
I like swimming, water aerobics, elliptical machines, stationary bicycles. Okay. There's this new thing called aqua jogging. Have you heard of this?
I haven't.
So they wear like a flotation device around their waist, and then they're literally jogging in water, but their feet are not touching the bottom of the pool.
Okay.
So it's obviously zero impact.
Stress. Yeah.
But they can get really high intensity out of that.
You can.
It's really hard to do.
Okay.
Yeah.
Now, are you also getting people to do physical exercise and cognitive exercise at the same time?
That's a really cool thing that our colleagues at the Pacific Brain Health Center are developing, which is the cognitive and physical dual tasking, meaning they do a cognitive and a physical exercise at the same time, simultaneously.
I'm not sure I can do that. Give me an example.
So the example I give is when I'm on the rowing machine and I have to go 150 meters, I try to add with instead of clearing it out to zero. I'm just going to do a little bit of math. I'm going to add instead of
add it on to what's there.
Zero it out.
Yeah.
Anyway, that's something simple.
Okay, so that's
honestly the type of examples that our CogFit gym is doing here. CogFit is they'll have people count backwards from 100 by sevens.
While they're doing what?
While they're on a treadmill, or while they're on an exercise bike, or while they're walking, between cones, or going left foot, right foot, that kind of movement. And then they will also have them do some mental arithmetic, as I said, or think of words that begin with the letter F, practice a foreign language.
All while you're doing a
physical. Now, for that one,
don't. Like if you're on a rowing machine or you're on a stationary bike, you're on an elliptical, you're doing this in your head.
Something safe, though.
Sure. You don't want to do this.
A lot of this is don't try it at home. Make sure your balance is okay before you try something like that. But that's what they're doing in the gym. What they're being supervised.
Now, what is that doing? How is that helping?
So the dual tasking appears to do more in terms of that. Efficiency, but also the creation of synapses.
No kidding. Okay.
Yeah. But it also, when you do physically exercise, your working memory, attention gets better. You also are releasing other beneficial neurotransmitters. Of course, the endorphins are important too. Exercise is really great for the bones, bone density, muscles, and heart as well. But the non-motor symptoms of Parkinson's, like anxiety, depression, insomnia, those can be improved with physical exercise as well. So there was a clinical trial that enrolled patients who'd had Parkinson's for about 6 or 7 years, and they divided them into 2 groups. One group was doing a milder fitness program, a little bit of stretching, this kind of thing. And the other group was doing progressive resistance exercises, meaning that weights or bands or machines, each week what would go on, they would have them increase the resistance or the number of repetitions they would do by a small increment. And then they followed these patients for 2 years. At the 6-month mark, both groups got better, were improved in their movement symptoms. At the 2-year mark, not only was the progressive resistance exercise group better than the control group, they were actually better than their own baseline at 2 years, which is a long period of time.
2 years
for a progressive
into
condition.
Parkinson's.
No, they had Parkinson's for 6 or 7 years.
Okay, but this 2 years
of the study.
They're still,
And at one point, there was a differentiation between how much medication they needed. The ones who were doing the more difficult exercise of the progressive resistance exercise actually needed less medication than the control group.
Less levodopa.
Yeah.
And you know that they need less levodopa because their symptoms are more under control. Is that right?
Exactly.
Okay. So that's a huge case
It's
for
huge.
exercise.
It's huge,
And
yeah.
okay, so what else did we mention here?
So for lifestyle, we talk about exercise. I do always recommend that people make a change to their regimen. If they're doing the same thing over and over again, their muscles are going to get bored, their brain is going to get bored, they're psychologically going to get bored. And I always try to emphasize that they challenge themselves to do something different, as well as something a little bit harder, just a little bit harder than feels comfortable to them.
So a few years ago, I decided I had to shake it up, and and I'm the least musical person in the world, and I started taking drum lessons. I'm the world's worst drummer.
Great.
But does that help?
I do think that's help. I wouldn't call that physical exercise. I would call that separate.
Okay.
So that gets into sort of social engagement and cognitive engagement. Learning something new.
But that's not enough of a movement?
No.
Okay. Okay.
It's the same as when people ask me about like, oh, well, I go vacuuming or I do this, I do that.
No.
Yeah, I mean, it's better than sitting and doing nothing all day long. It is activity, but it isn't the same as doing these kinds of
Okay, so I interrupted you though. Get that.
So basically, we talked about exercise, and then there's diet.
Okay.
So we don't have as much strong data on diet, but there's reason to believe that the MIND diet, which is the Mediterranean Intervention for Neurodegeneration Delay, MIND,
okay,
which is an offshoot of the Mediterranean diet, essentially, has been associated with a reduced progression of Parkinson's disease, has been associated with less risk of developing Parkinson's disease. So I think there's reason to believe that people who have Parkinson's would be wise to keep this diet.
So that's
green leafy vegetables, other vegetables, whole grains, fish and poultry, olive oil, nuts, berries, and beans. I'll leave it at that.
Okay.
And then avoiding red meat, cheese, butter, fried food, and sweets.
This is a non-inflammatory diet, isn't it?
Yeah, it does seem like those other things that are the bad things, like there's some people who have inflammation with dairy products or with processed foods, lots of sugar.
What do we think those foods are doing to this dopamine system?
I take it back from dopamine. I take it into that earlier question about inflammation contributing to those toxic forms of alpha-synuclein being formed.
That's where we need. Yeah, that's what we need to bear in mind.
You want to go back up the stream. Yeah. Mm-hmm.
Okay.
And the other aspect of diet, as far as the green leafy vegetables and the water, is trying to be aggressive about managing constipation.
Okay.
Because when you do have constipation, that contributes to the bacterial imbalances. That can very interestingly actually affect how people are metabolizing their levodopa. This is really groundbreaking research that came out in 2019 showing that we don't just have our human enzymes metabolizing medications. We actually have to worry about bacterial enzymes and the bacterial levels and how they are inactivating medications such as levodopa.
This is our gut biome.
The gut microbiome.
Microbiome inactivating levodopa.
Exactly.
Okay, so you want to optimize your gut biome to, is that the right way to say it?
The problem is we don't really know how to properly optimize the microbiome.
Right.
What we do know is do the things you can do. For example, treat constipation, eat a non-inflammatory healthy diet like we talked about, exercise will all play a role in that. Because of course exercise then can reduce constipation too, right?
Right. Okay.
The other things we know are if you can avoid, let me take a step back. The other thing we know is that people with Parkinson's are more likely to have something called small intestinal bacterial overgrowth, SIBO, which needs to be diagnosed by a gastroenterologist and then can be treated specifically based off of which of the bacteria are overgrowing.
Interesting.
And that's important to look into with a gastroenterologist.
What causes that?
Again, I think that goes back to the chronic constipation contributing to, but we don't exactly know.
And these are growth of what bacteria?
So one of the quote-unquote bad bacteria is Enterococcus faecalis, and the other one is Egerthella lentii.
Well done.
Yeah.
Okay, so these are flora in our small intestine that are
and they may
too
not
many.
be bad in and of themselves,
right.
but when they take over the joint, they become bad actors. It's all about the balance of it.
So what was groundbreaking about the research?
Well, the idea that it's not just human enzymes,
Okay,
it's
right.
also bacterial enzymes.
To keep,
And so there's work being done on how do you manage those abnormal bacterial enzymes that I think will come to fruition hopefully soon.
How do you manage them through diet and
it's not,
who knows?
Unclear.
That's fascinating.
One thing we don't think should be recommended in general is probiotics, because there's no evidence that probiotics work to actually recreate a proper bacterial profile. And some probiotics actually have those bad bacteria in them that can inactivate the levodopa.
Yeah.
So I don't recommend probiotics unless at some point in the future, some kind of properly, managed probiotics.
What about kombucha?
So kombucha isn't kombucha the fermented stuff?
Yeah, it's
people who are taking certain Parkinson's medication need to be careful with
kombucha.
Fermented foods.
Really? With fermented foods?
Fermented foods.
Okay.
Yeah, that's a whole other thing. We also have a program that was developed by the American Parkinson Disease Association and is supported here with grant funding through the APDA called PRESS. So PRESS stands for Parkinson's Roadmap to Education and Support Services. And it's an 8-week complementary program where the participants meet once a week. And each week there's a different topic on the curriculum for some small amount of education that comes from our nurse practitioner, Giselle, and our social worker, Sheila. And then the other half of that session is a support group that's moderated by them, where they are communicating with each other of what's helping them, what they're thinking they're going to do for their future, what their concerns and struggles are, the things that they're finding to be challenging, so that they can connect with each other.
So this is a group.
This is a support group, but it's different from a regular support group in that it's limited to people who've been recently diagnosed, so within the past 3 years. And it's a closed group, meaning that once the 8-week session begins, then it's only that group of participants and their care partners or spouses or family member that they are bringing with them for the full 8-week session. And it's a much smaller group.
And you close it because you want to have
people get to know each other. Plus, there's a curriculum. So each week they're going to have a different topic of conversation. And then after the 8-week session, then, we have, this ongoing as a quarterly. We'll have another PRESS program beginning in May, for example. And what's really important is that people who've been recently diagnosed with Parkinson's have very different needs as far as the type of support they need and the things that they're worried about compared to people who've had Parkinson's for much longer.
Sure.
It's really interesting because I found that people who are newly diagnosed might not have a lot of limitations with their movements. Maybe they have a little bit of tremor, but it's not really bothering them. Or maybe they're taking their medications and they're feeling really good with the medications and they're still able to work or function or exercise, but they're just feeling really unmoored and ungrounded in terms of what is happening to their life, where they're going from here, what does it mean as their role in their family, like maybe they were the patriarch or the matriarch of the family and now they're not sure what this means for them. And so it's a really, really different set of anxieties compared to somebody who's, for example, like your friend who already has dementia and is doing really poorly, and their spouse or family member might need more support with, caregiving or, nursing homes or those kinds of, using a walker, et cetera. Those kinds of concerns in advanced stages of Parkinson's are really challenging for somebody who's newly diagnosed to sort of grapple with and worry about when it may not be something they have to contend with for many, many years. So that's why I think it's really great to have a group where there's people who are, still active and engaged and, just trying to think about what can we do now as a preventative.
How long is that? How long has PRESS been going on?
So PRESS started as a pilot program through APDA. I'd have to get back to you on an actual year.
No, just ballpark. I mean,
probably
you
a
have
few
some.
years ago.
Okay, so
and then we started it at our first session. Our first 8-week session was last fall, and then we're on our second session now.
I wonder if people in those groups stay together, if they,
so
if they keep that community or not.
What we did was we advised them to, exchange phone numbers so that if they wanted to, like I have some patients who don't participate in formal, institute-based support groups, but they have a good group of girlfriends who all have Parkinson's that they've met through an exercise class, for example, and they get together and they have their ladies who lunch. Or, sometimes, they'll be a care partner will be at a class and, they will start communicating with each other as their spouses are exercising.
Yeah.
And they'll, exchange phone numbers and get together and that kind of thing.
And this is all for the good. This is social engagement you're talking about.
Absolutely. Because the isolation is so common. It's really crazy because a lot of people with Parkinson's don't know anybody who's ever had Parkinson's disease. Like I said, most people don't have a family member. Yeah. A lot of people don't even have any friends that they know of. Or if they do, it was somebody who didn't do well and now they've passed away or something like that. And so, they feel really isolated, like they don't know who they can open up with about, hey, I'm really struggling, or I have a hard time when I'm in a conversation with a group of friends where I feel like I can't keep up with the conversation, or those kinds of things. Sheila, our social worker, is going to do a quarterly check-in with them so that they'll get them back together, like a reunion, get the gang back together and sort of check in with people and see how they're doing.
Yeah. What percentage of Parkinson's patients develop dementia?
Unfortunately, this is sort of the dirty secret. We don't like to really get too far into it when people are first diagnosed because it's really alarming to them. But unfortunately, the majority of people, if they've lived long enough with Parkinson's, do develop some degree of dementia. It's really important to clarify here because I find that most people don't know the differences in the definition. Dementia is not the same thing as Alzheimer's disease. So people with Parkinson's are not going to go get Alzheimer's disease in high degrees of likelihood, but cognitive decline to the point of causing some difficulty with some activity of daily living. So, for example, if somebody had to stop working because they just couldn't remember all the details, or they were missing appointments, or they just couldn't do the financial calculations as well as they used to, but they're still looking really great when they're talking to you and having a conversation and taking care of all of their daily living activities. Otherwise, they would still be considered as having mild dementia because there's something that they used to be able to do and they can't do it anymore, even if it's mild.
Okay.
Dementia can be caused by a number of things. One of them is Alzheimer's, of course, but Parkinson's can also do it, as well as something called dementia with Lewy bodies, which is really thought to be a kind of cousin of Parkinson's disease. It's in the same kind of family.
How does Parkinson's cause dementia?
So unfortunately, the alpha-synuclein that we were talking about starting in that deep part of the brain, the autopilot, it spreads over the years to the cortex and to the rest of the brain.
Okay.
I should say mostly subcortical. Usually it doesn't quite as
so that's
far
what's
out,
going
but it
on
spreads
there.
out. Yeah. Let's talk about what the internet can do in a positive way.
Yeah, sure.
So there's a lot of really great websites for Parkinson's. One of them is the APDA, which I should say that we at Pacific Movement Disorder Center are an information and referral center for the APDA.
Okay.
So what that means is Sheila, who's our social worker, as I mentioned earlier, is the information referral coordinator of the whole Southern California region for the American Parkinson's Disease Association. So this is a nationwide association, and they've chosen to partner with various institutions. Like, for example, up north, it's UCSF and Stanford. In Southern California, it's Pacific Neuroscience Institute, where Sheila is not just helping our patients, she's also the point person for people all across the region to contact her and ask a non-clinical question, like, how do I get connected with a boxing program? Can you tell me who is a good, speech therapist in Bakersfield? Those kinds of things. So she is helping our patients, but also the greater community in learning about Parkinson's, advocating for themselves, finding out, what resources they need. And then the other thing that we're doing with American Parkinson's Disease Association is we're going to be putting on a seminar later this year for patients with the theme being about engagement and connection with the community so that people can understand how to advocate for themselves, how to read the news in a sharp kind of way, how to know,
consume information in a smart way, and know what's
how to know what's useful,
scientific, what's
versus what's dubious. How to start a support group, for example. There's a lot of patients who have started their own support groups. So that's the kind of help that we're trying to bring to the community, not just our own patients, but also other people in the community. The other thing about the internet, so the APDA has a website, Michael J. Fox has a website. There's a lot of really well-written blogs about Parkinson's that I think are really helpful for raising awareness, as well as, maybe there's a medication that you want to ask your doctor about, or learning about deep brain stimulation surgery, for example, because it does take a little bit of reading about it, learning about it, either through the internet or through support groups, to have people feel a little bit more comfortable with the ideas of doing these kinds of treatments. That I think the internet can be actually really helpful.
Is there any hope out there for the magic drug that's going to cure Parkinson's?
So I don't like to use the word cure, because I'm not as optimistic of that. The cure concept would be a treatment that you would take once or some short series of, and then you would be done with treatment and never need any medication ever again and not have Parkinson's disease.
Right.
I'm not quite as optimistic for that, but I am very optimistic that we're going to have better treatment that will do a much better job of slowing progression. I am hopeful, and I think it's a realistic hope, that in my career, what I'm going to see is a paradigm shift in how we diagnose Parkinson's disease. I think we need to do better at finding people earlier, because a lot of these neurodegenerative diseases, once they've had the disease for too long, it may be that too little, too late kind of phenomenon happening that we saw in the Alzheimer's studies that have been unfortunately disappointing. So I think Parkinson's has these non-motor symptoms like the REM sleep behavior disorder, the smell testing, et cetera, that could lend themselves to screening in the appropriate population. So for example, you would take somebody who's the adult child of somebody who has Parkinson's disease, and they may have a doubling of their risk, but their risk might go from 1% to 2%. Right? So they may have 98% chance they're not going to get Parkinson's, but we might be able to do genetic testing. We might be able to do smell testing. Well, let me take a step back. We can now today do genetic testing and smell testing.
Genetic testing that tells you
if they have a gene that's putting them at risk of developing Parkinson's.
So we know disease. What that gene is.
No, there's multiple. Okay. So there's at least 16 or more genes that have been identified. That we know when you have that gene, it puts you at risk. It doesn't mean you will get Parkinson's. It means you might be at a greater risk than somebody who doesn't have that gene. But even people who have it in their family, we might do genetic testing, might come back negative. So there's probably other genes that we're not aware of yet.
Okay.
So my idea for what that kind of evaluation is going to look like is going to be, we'll do the genetic testing, we'll do smell testing because that's very non-invasive. We might do a sleep study, for example, to look for REM sleep behavior disorder. And then we'll calculate a risk factor. There's actually research being done on this, and it's called the PREDICT score with the C as a G. And so it's like environmental factors such as pesticide exposure, smoking, etc., your age, the genetic profile, whether or not you have REM sleep behavior disorder, whether or not you have a loss of smell testing. And that is used to make a score of you're at, let's say, 10% risk of developing Parkinson's in your lifetime. And then what we need is a better biomarker for, are you brewing Parkinson's disease?
That's a really interesting way to put it.
Do you have Parkinson's disease, but you're in early stages of it? And once you have Parkinson's disease established, where are you at? How are you doing? Are the treatments that we're giving you helping to slow progression of Parkinson's? So an example of a biomarker is, say, blood pressure, right? Blood pressure is a way of assessing your risk for heart attack and stroke and vision loss and kidney disease. Yeah. It doesn't mean you are going to get those things, but it is something that we can treat. It's non-invasive. It's very reliable. It's cheap. It's easy. You can do it at home. And it can be repeated over, we can give you a treatment and then we can measure it again and see how are we doing on your blood pressure.
Right.
So that's what we need for biomarker for Parkinson's. It doesn't necessarily equate exactly to how is somebody doing clinically, but the clinical outcome is like years down the line compared to what was causing the Parkinson's in the first place, how it developed, and what we're doing to try to prevent it
So what do you imagine as a biomarker for
So one
Parkinson's?
of the things that's interesting is like salivary assessment of alpha-synuclein, or even retinal scanning, looking for alpha-synuclein deposition, something like that, where it wouldn't require a biopsy or a spinal tap.
Right.
Something, there are blood-based, biomarkers that are being looked at. So some kind of blood draw type thing, something that's cheap enough, reliable, and repeatable.
I interviewed somebody recently who had a ring that tracked his REM sleep, his sleep in general.
Mm-hmm.
And I can imagine, and that maybe that's not it, but down the road, I could imagine something that would be cheap, affordable,
so
hooked
there's
into
a
our
lot
phones,
of work right now already on that kind of thing. So we call
maybe
that
a clue.
Yeah, so we call that wearable sensors.
Yeah.
Like there's a lot that's already being developed on that. So they can assess for tremor. There's like risk-based. There's actually one that is already available called the PKG. It's the Parkinson's kinetograph. So people with Parkinson's can wear it, and then it can differentiate between tremor, slowness, meaning bradykinesia, immobility, meaning they're either asleep or they're just not moving enough, dyskinesias, which are the complications of treatment. And then give a score over, not a score, but a kind of a graph of what they looked like over a week period of time relative to how they took their medications, et cetera, how much off time they're having, how they're we need to talk about how they responded to the medication, et cetera. But that's, there are also people who are looking at, well, if you type in a certain way, like on a keyboard, is this able to detect Parkinson's earlier? So to me, that's still too clinical. That's still too far down the line. I'm interested in, alpha-synuclein, like what's actually happening in the brain.
Oh my God, that's...
So anyway,
there's a lot of hope here.
So wait, there's more hope. Okay. So that's the idea of like...
But there's more hope.
A paradigm shift in how we make the diagnosis and how are we monitoring people.
Yeah.
Because right now, the way I monitor people is they come in and I ask them how they're doing, ask them if they've fallen, ask them how they're doing with their meds. I do the exam and I use that number as something to monitor. Well, you were 25 last time, and then the time before that you were 19, and now you're 44. You're going in the wrong direction. But that's really too far down the line. As I said, it's too far downstream. So, and plus it might relate to, how did you sleep last night? How did you take your medications? How motivated are you? What mood are you in, et cetera. So once we've had, better biomarker, better way of monitoring, then the treatments that are really promising now are what I'm envisioning, and what I think a lot of people are thinking, is that it's going to be some kind of cocktail approach.
Sure.
It's not going to be one magic pill.
No.
It's going to be, hopefully, there's a lot of optimism about these antibodies that are in phase 2 clinical trials now, that are antibodies against alpha-synuclein, against the toxic forms of alpha-synuclein. Try to clear out the abnormal alpha-synuclein. There's genetic testing being done, genetic modification, essentially, where, for example, if somebody has the GBA gene, which is something that can cause Gaucher disease, but it's also associated with Parkinson's, if you can modify the effect of that gene by helping with the effect of what that gene product was doing, which is called the lysosome.
Okay.
You can help clear alpha-synuclein better.
Again, okay.
There's work done on the diabetes medications, the GLP-1 agonists, because there's evidence, again, connecting back to how sugar is toxic. The diabetes medications working on glucagon appear to play a role in the neuroprotection pathways. So there was a study in the Lancet that showed that there was less progression in people who were getting one of the diabetes medications versus people who were getting placebo.
So this is stuff we have got to do another one of these about all of that, about those. That's a huge subject, and that would be fascinating to talk more about, because that all sounds. I didn't know any of that, but that's all on the horizon.
Yeah. So I think that probably it won't be one of these enough on their own.
Yeah.
I think it's going to take a few of these. Plus, I think people will still need levodopa.
Sure.
But hopefully we'll have better forms that last longer.
Yeah.
That maybe can be taken only 2 or 3 times a day instead of like 5-6 times that some people are getting up to.
Doing. Right. That's what.
We, as we said, we still have deep brain stimulation surgery, which plays a different role than medication does.
Yeah.
That can be really helpful in certain cases.
Excellent.
So I think there's going to be a lot of different ways, but it still will go back to what the patients are doing for themselves, how they're advocating for themselves, how they're exercising, how they're engaging socially, how much sleep they're getting, water, diet, etc.
Yeah, that makes a ton of sense. This has really been fascinating. I really appreciate your time.
Thank you.
All right, Dr. Petrossian, thank you very, very much.
Thank you for having me.